So as was mentioned in my introduction, I was diagnosed with breast cancer at the age of 23. It was just about 2 years after I found a lump in my breast. It took that long for a doctor to take me seriously. I went from doctor to doctor, and I kept being told that women my age, I don't know why that's weird, don't get breast cancer. At the age of 23, I had graduated from college. I actually graduated from college when I was 18. I was married. I had a newborn baby at home, and everything was going right. Why does that keep switching? It was quite a tragedy to hear this. My whole life kind of fell apart. I wasn't able to work. My husband, who I had been dating him since I was 13 years old, left when he found out I was diagnosed with breast cancer. So I had a new baby. I was in graduate school and trying to work. And my doctors did a really great job of removing the cancer, but I often say they did a really good job of getting me better, but they didn't get me well. So I had a lot of issues at the end of treatment. I was left completely exhausted. I couldn't get out of bed. I was a triathlon before I was diagnosed with cancer and could not physically get out of bed. I was depressed. My body had been mutilated. I had 36 surgeries in 18 months to try to get back to a sense of health. So in 2009, we started the Johns Hopkins Breast Cancer Survivorship Program, and this was really a partnership between several schools, which I'll go into in a minute, to try to address the needs of women at the end of treatment, so kind of the next stages of life. So just to give a little bit of background, the National Coalition for Cancer Survivorship looks at survivorship from the time of diagnosis to the end of a patient's life. So it's once you're a survivor, you'll always be a survivor. When we're talking about things like infertility, it's really important to kind of incorporate survivorship from the very beginning. I often ask patients in my clinic, what are you hoping for? So very young patients.
Sorry,
am I not?
It's not so loud. Sorry.
Oh, sorry. Thank you.
That's better.
Is that better? Okay. So when we talk about things like fertility, if we could intervene early before treatment starts, we know that we have a better outcome. So the idea of looking at survivorship along the continuum is really important. Also the idea of looking at the co-survivor. So the idea of who this woman is going to be, who's going to be taking care of this patient while she's going through treatment. I think there's not a lot of attention on the caregiver, and I often hear men or other people in my clinic saying things like, no one ever asked me how I was doing, and I don't know how to deal with this, and I'm trying to juggle having kids at home and taking care of my wife and working, and she was the one that did everything, and now I don't know how to handle it. So this idea of looking at the co-survivor, I think, is really an important thing. So just to give you a little bit of background, as of earlier this year, we know that there are 14.5 million cancer survivors alive only in the US, so quite a big number. And this number is expected to rise with baby boomers getting older. We know that this number is going to increase. As shown here, about 30% by the next decade will have an increase in cancer survivors. And by 2014, we're expecting about 19 million cancer survivors only in the US, so that's quite a large number. And 64% of cancer survivors have been alive for more than at least 5 years. So we're knowing that these cancer survivors are living a long time, and they're living beyond their treatment, that they have a lot of medical and psychosocial needs that we need to address post-treatment. This graph shows a little bit about the increase, and once again you can see about how the baby boomers are getting older, and you can see a direct incline in what we're going to need to do in terms of a workforce of taking care of these patients. They're going to be getting older, they're going to have issues, and we need to have an infrastructure to be able to deal with them. So the good news is that people are surviving their cancers, specifically in breast cancer, women are surviving their diagnosis. We tell women with early detection saves lives, so the idea of things like mammograms or with colon cancer, things like colonoscopies. The screening, we know that if it's caught early, you've got a higher chance of survival. So we know that if we detect it early, they'll do better, and so since we're detecting cancer early, these women are surviving. We also have research better than ever in terms of what we can do to prevent cancer. So this idea that we know that there's a direct correlation with what you eat and the idea of you possibly getting cancer, as well as exercise. We do know that women who exercise have a less likelihood of getting cancer. Additionally, we have lots of new treatments available. So the idea of in breast cancer, we have certain targeted therapies. These are treatments that go specifically to the cancer cell and leave healthy cells alone. So these targeted therapies that are kind of magic bullets that track just the cancer cells and are able to tackle those and kill those while leaving everything else healthy. The idea of neoadjuvant treatment, which is this idea of we're able to give chemotherapy before we have surgery with breast cancer, that idea actually shrinks the tumor, and we know that in some cases has better outcomes. And the idea of combination of therapies. So it used to be that there would be one standard chemo with one type of breast cancer. We now know that there are many different types of breast cancer, and we can combine specific drugs and other treatment modalities to improve outcomes. We also know with these improvements in outcomes, we also are able to look at things like toxicities, and we know that certain treatments we're able to measure them better and be able to reduce the level of toxicity that's making women very sick. And knowing all these things, we'll have the ability to drastically reduce the chance of second malignancies as women age and they survive their breast cancer. So this gives a very busy slide, but this keeps moving. Sorry. This is a very busy slide, but so we talk a little bit about what happens at diagnosis and this idea that women go through a lot of emotions. How did this happen? I did everything right. So that slide basically talks a little bit about the idea of what happens when a woman's diagnosed with cancer. And so there are lots of things that she's experienced. Why did this happen to me? Did I have a genetic mutation? Did something in my family happen? Was it that I drank too much or that I smoked? And a lot of women, they have no actual risk factors when they get diagnosed with breast cancer. So about 80 to 90% of breast cancer patients that we see, there's actually no known factor of why they're diagnosed with breast cancer. So they're going through all these different emotions. And then they go through treatment and they have a very busy time trying to figure out which treatment, which doctor to go to. And then usually what I find in my clinic is that once, thank you. Okay, hopefully this works. Okay, so when they get through treatment, after there are lots of decisions that need to be made in terms of what treatments they should receive, which doctors they should go with. And once that's done, I find that there's actually a calm that happens at that point, that patients kind of go through the motions and they go through their chemotherapy and their radiation. But then they get to this period of survivorship when treatment is over and they kind of realize, like, this idea of what have I just gone through? And they're dealt with a lot of emotions. These are when things like people stop helping out with the kids and people stop bringing over foods and thinking that you're healed and that you're better. But actually we find that the period into survivorship is one of the hardest times after a woman is diagnosed. So this idea of trying to develop resources to tackle some of these things is really important. And this is a study that was done by the Livestrong organization in 2010 where they looked at a little over 2,000 cancer patients. And what they found was that over 98% of cancer patients report one or more symptom or side effect after treatment. So those are huge numbers. And 86% report that they have two or more of these symptoms at any given time. And these symptoms can last, not just right after treatment, but up to 5 years. So finding ways that we can tackle these things to improve quality of life for our patients and their families is really important. So this talks a little bit about the scheme of what happens when a woman is diagnosed with breast cancer. So after they get the initial diagnosis, generally they'll go through surgery, they'll go through medical oncology and have about 6 months of chemotherapy, followed by about 6 weeks of radiation. Radiation's given daily, 5 days a week for about 6.5 weeks generally. And at Johns Hopkins, what we do is after they go through this very busy period, they go through what's called a survivorship transition visit. And this was actually what was established as part of our survivorship program at Johns Hopkins, that we were realizing we were doing a really good job, as I mentioned before, of removing disease, but not so much of a good job of taking care of patients at the end of treatment. So this idea of going through with a woman, what's just happened, so this idea of a treatment summary of everything the patient needs to know. We were having patients that were leaving treatment and you would say, what happened? And they would say, we had breast cancer. And they weren't able to tell their doctors about what type of breast cancer they had, what type of treatments they received. So this idea of having some type of treatment summary is really important for coordination of care. So primary care providers and patients can kind of be their own advocates to talk about next steps and what needs to happen to improve overall health and wellness after treatment. And then as you can see all the way here on the far column, that lots of other visits occur after initial treatment is over. So there may be some type of genetic screening that's done to determine why a woman did get breast cancer in the first place. She may go through reconstructive surgery, and this can be a very lengthy process. This is often usually done over several visits, several different surgeries, and it takes a very long time to get women to feel almost back to normal. You know, I talk a little bit about the idea of feeling like Humpty Dumpty after my treatment and just wanting to become whole again, and that took a really long time. We also know that women often have a lot of emotional issues, high anxiety about fear of recurrence, about what they've gone through, as well as depression about what's happened, this kind of feeling of I don't trust my body anymore, that my body has failed me. So the idea of providing good psychosocial support and what that may look like. For some women, that may be things like support groups, or it could be things like one-on-one support with a counselor. Also, the idea of bone health is really important. So we know that a lot of our treatments can cause problems with osteoporosis and bone health. So making sure that her bone health is taken care of long term. And cancer rehab is something that I find to be really important. So we do a lot with deconditioning women. They have very invasive surgeries that can affect shoulder mobility. They can affect even pelvic floor health, the way that their whole body is aligned. And getting patients back to the kind of this idea of a new normal is really critical. I have frequently see women in my clinic who will say to me, well, after surgery, I didn't really get out of bed, and so they're completely deconditioned. So this idea of trying to figure out ways that we can preemptively work with them in a cancer rehab with physical therapy to hopefully prevent that or mitigate some of those things so we're not having to undo a lot of things. Sexual health is another really big one. A lot of our treatments really do a number on sexual health, and the idea of body image is an issue, as well as some of our treatments cause all kinds of menopausal symptoms. And then nutrition. I get a lot of questions about nutrition and this idea of how to stay healthy after cancer. And patients really want to know what they can do, kind of this idea of empowering themselves, of what they should be eating, what they shouldn't be eating, and how they can stay healthy. So when we look at the idea of survivorship in breast cancer, the good news is that we know that patients are surviving their cancer for the most part, especially when it's caught early. But we also know that there's a huge unmet need when taking care of these patients long term. I'll tell you a little anecdotal story. When I finished my cancer treatment, I went to my internist, who was a Johns Hopkins doctor. He was really smart and actually pretty famous. And I said to him, well, what do we do now? And he said, I don't know what we need to do now. So I literally took out the sheet with him and I said, well, let's order a brain scan, an MRI, a bone scan. I just said, let's just scan the whole body. Let's just keep looking for things. The reality is that was completely not evidence-based and probably put me at risk with all kinds of radiation that was completely unnecessary. But this idea that I was very fearful, so the idea of more tests in my mind equated with better care. And we know that not to be true. But we have to educate our patients and educate our providers of what good care looks like and how we can have the right care at the right time for these patients. So what that looks like is the idea of coordination of care between, and I would actually even put with patients and healthcare providers. I kind of look at this as a triad with the idea that patients should really be in the middle and they should be kind of driving the bus, and then picking good doctors after their cancer treatment. That includes good GYNs and primary care doctors and other healthcare providers that are able to incorporate not just their cancer, but look at the big picture of making sure this woman is not at risk for cardiovascular disease or diabetes or other health issues that she may be at risk for that have nothing to do with her cancer, but that are important in terms of her overall health and wellness. The idea of adherence to surveillance and health maintenance is really important. I tell my patients it's really important that I want to take you from pink to red, to this idea of moving you beyond worrying about cancer and worried about heart disease. The #1 cause of breast cancers, women to die, is actually not breast cancer, that they're more likely to die of heart disease. So the idea of finding ways that they stay healthy is really, really important. And we know that all of these things do have the capacity to improve outcomes. So right now, given our U.S. healthcare system, care is really fragmented. Patients who come to places like Johns Hopkins or other medical centers in this country, they may go somewhere for their cancer care, they may go somewhere else for radiation, they may go somewhere else for primary care, and these systems don't talk to each other. So the idea of primary care doctors can't look into a medical chart and see exactly what's happened and how to take care of that patient. So finding out ways that we can coordinate care is really, really important. As well as this idea of patient activation and making sure that patients, once again, drive that bus and they're able to be in charge of their own care, I think is really important. And I'm not expecting patients to go in and say, I want this test and this test and this test. But they should know a little bit about what the test that they should be getting annual mammograms, or if they should be getting colonoscopies, or what kind of other tests that they should be getting, and working in partnership with their doctors. So this is a little bit about what we did at Johns Hopkins. Once again, I mentioned I put patient-centered care in the middle because I really think that patients should be in the middle of that. And this was a partnership that we formed in 2008, 2009, and it was between the schools of medicine, the schools of nursing, our cancer center, and the Bloomberg School of Public Health, with the idea of looking at how we can better improve outcomes for our cancer patients after treatment is over. So the first thing that we did was we started with a needs assessment. So we did a lot of interviews and focus groups trying to get a sense of what's currently being done and how we can improve it. One of the things that we found, which I thought was particularly interesting, is our cancer doctors were saying, I don't want to transition my patients. I want to keep my patients close to me. I want to keep seeing them on a regular basis. But the reality is that these same doctors were waiting 6 weeks, 2 months for a new patient to come in, which is completely inexcusable. All of their visits or their slots for new patients were being filled up by return patients, which ideally is great. So I call them these kind of well baby checkups. It's really great to see pictures of the grandkids and to kind of see how people are doing and to see when things are going well with cancer, and instead of all those really hard visits and those hard conversations we have to have with our patients. But it really isn't practical. And the reality is that we do have to transition these women back out of oncology and into primary care, so we have room for space for new patients coming in and they can get seen in a timely fashion. The other thing we heard from primary care providers across not just the region, but even internationally, was that they didn't really know what they needed to be doing to take care of breast cancer patients. There was a real limited knowledge about what tests should be ordered, what patients were at risk for, even what treatment options were being available to patients. So these treatments are changing all the time. It's not in the continuing education medical literature. So primary care doctors really don't know what they should be doing in terms of taking care of patients and what they should be doing for next steps. And then we also heard a lot from patients, and patients were saying, I don't trust my primary care doctor knows these things, and I really feel like I want to go to my oncologist because he or she knows my cancer and knows how to prevent it from happening. So this idea of trying to educate patients and providers that it is safe to go back to primary care as long as primary care has the right tools available. And what we found was that if we were able to develop modes of transition to ease transition, we could improve outcomes and hopefully make coordination of care better between all the providers involved. So this is also a very busy slide, but we also talked to patients about what good survivorship care looks like. And we found that there were lots of needs that weren't just medical needs of what patients needed after a cancer diagnosis. So it's very busy, and some of these things, providing things like nutrition and exercise are things that we can do in a medical facility, but things like smoking cessation and support services, we also need to be able to have community resources that we're able to refer out to. But we were hearing from patients that they would most likely take advantage of most or all of these services if provided to them. So we started in 2009 offering patients this idea of a transition visit, as I mentioned earlier. And this was the idea of our patients sitting down with a nurse practitioner at the end of treatment, creating a treatment summary of everything that has happened since the end of breast cancer, as well as coming up with a survivorship care plan. And what this looked like is everything that needs to happen medically and psychosocially going forward. So what screening is necessary to make sure that no new cancers arise, what surveillance is necessary to make sure that the cancer that they had doesn't come back or spread, as well as what other health maintenance ideas. So should they be getting colonoscopies? Should they be getting cardiovascular tests? Should they be getting screened for diabetes? What about vaccinations? How often should they be going to primary care? Should they be getting mammograms? So those types of things we talk about at these transition visits. We just piloted this idea, and this just gives you a little bit of a breakdown of the patient, the ages that we're seeing. So we're seeing on average a little bit younger than what we see in breast cancer. The average age of breast cancer is between 61 and 63. So this tends to be a little bit younger, but it runs across the gamut in terms of age distribution. And some of the interviews, we found that patients really felt like this was very helpful. They thought that this was helpful to coordinate care, it reduces anxiety going forward. We also felt like I was starting to get all these calls from people that weren't necessarily treated at Johns Hopkins, and these were calls coming a lot from around the area, but also internationally for patients saying, I've had breast cancer, I don't know what I need to do going forward, can I come to your clinic? And we really didn't have the resources or the infrastructure to be able to do that, but it got me thinking that we should really be providing education to everybody and not just patients that have the luxury of being treated at a place like Hopkins. So we started looking at ways we could educate the masses in a way that anybody could have access to free educational information when they were ready to receive it, which I think is also really helpful. We used to give patients when they were newly diagnosed, and I would also experience this, we used to give them pamphlets and handouts and all kinds of things about their cancer, and it just was too much early on in diagnosis. So some of these things felt like it was really important to do it when they were ready to receive it. So we started looking at what kind of technology we could use to try to increase education. And this is one statistic that the Pew Foundation says that about 85% of Americans are online on a regular basis. So we were finding, and even in inner city areas and very impoverished areas, that people that don't even have computers in their homes have smartphones, and they are using this technology on a daily basis. So we started with trying to develop an interactive website where we provided lots of different things that people could possibly think of when it comes to breast cancer on our website and how we could really expand some of this educational content. And then we decided that it would be really helpful for survivors to hear from other survivors about what they were experiencing. So we did a series of focus groups with me sitting in a room with patients and saying things like, how is life after treatment? How are things with your kids? How is it going back to work? What are some of the things that you're scared of? And telling these people, pretend like the cameras aren't even in the room, and we would film these and put them into short video clips and put them out for other survivors to watch. And it was really interesting that survivors really enjoyed hearing from other survivors and were able to say, hey, I feel like that too, and they're able to relate to some of these things, which was really helpful. And then we said, well, we have such a wealth of information here at Hopkins and even within the Baltimore, D.C. area. What if we were to take some of these really brilliant doctors that we work with and interview them on topics that patients are constantly wondering about? So things like nutrition, things about rehab, things about sexual health, that they may or may not have time to ask their doctors, or their doctors may not have that information on. So we've done about 65 videos with me interviewing different providers and a series of very short 10, 15-minute interviews and asking them questions about what patients need to know at the end of treatment. The other thing we do is I write an ongoing blog about things that I've experienced as my own going through cancer, as well as what I see in the clinic a lot. So I try to do this every few weeks of a new topic, a new research idea, a new clinical trial, a new issue that we hear. And this is our newest initiative that started about a little less than 2 years ago, which is I've been pretty excited about, with this idea of webinars. So we started offering webinars in the beginning, of September of 2012. And this idea was to provide patients the ability to not just listen to information, but to ask questions. So we started offering quarterly webinars and really was amazed at how pervasive it got on social media. We just started putting it out there, and it was really interesting to see how this was picked up in the international community and even around the country, of people saying it's really great to be able to listen to a presentation and then in real time, with kind of the anonymity of people not knowing who I am, ask questions to my doctor, to these doctors. So things like our sexual health one, we had a huge following. We had 5,000 people that registered right away. This idea that people really wanted to know this information, their doctors weren't talking about it, but they did have questions and wanted to follow up on them. So here's a list of some of the topics that we've done so far, and we've got several more coming up in the next several months. And then I mentioned it's the format of the 30-minute presentation followed by live Q&A. We archive our webinars on our website, and we have them available for download at any point in time. And they are being utilized about 10,000 times a month, so that we are knowing that there's a pretty good reach around the world with them. And then afterwards, with people that participate in our live webinar, we do ask a 9-question satisfaction survey, which I'll show you some of that data so we can try to help improve these things. So this gives you a breakdown of the people we're seeing. The age range is pretty diverse. I'll tell you, the 81-year-old actually called me and didn't have a computer, didn't know what internet access was, so she actually had her son come over, bring over an old computer, and she needed an email address to register, so I actually sat with her and said, go to gmail.com and put in your name, and these are things that, at least for me, I take for granted for. But it was really neat to see an 81-year-old woman kind of get with this technology, and throughout the whole webinar she kept saying, can you see me, am I on? And she was really excited about the ability, and she kept asking, I think I probably got 30 questions from her in about 45 minutes, and it was really cute. Which is really neat to see. You can see a little bit about how we're advertising in the email, the number that's a little bit inflated, because once we capture this information in our data set, we then are able to then email them about subsequent webinars as well. And you can also see that these women are done with treatment, but they're just done with treatment. So they're still pretty new outside of their cancer diagnosis. And there are several countries, which we'll look at in a minute. It's pretty well diversified. This gives you a breakdown of some of the patients we've seen in the last couple webinars. So I think this is the last 2 webinars of some of the breakdowns of international participants. So there is a good reach that we're getting internationally. We've definitely heard from women in places like Saudi Arabia that saying that none of this information is available. And the other thing we've done for some of these women is we've had viewing parties where women get together, they watch it together, and it's something like a support group. And then we'll stay online for an hour after the webinar is over and do a live Q&A with just that group. So it really gives them access to be able to ask questions and have access to some quality doctors that they may not otherwise have in the specific topic of interest. And these are just some satisfaction data, and they're soft numbers, but you can tell that people are really looking to gain more knowledge when they're participating in webinars, and they're overall pretty satisfied. One thing we heard is that there's just not enough time for questions, and so we're playing with the idea of expanding it, although I kind of question the idea if it was longer than an hour would people start to lose interest. I think I personally would. But if there are other formats of whether we can get questions ahead of time or what that might look like. And then the other things that we've done within Johns Hopkins is the idea of train new trainees coming up. So the idea of hoping that this lack of knowledge isn't pervasive as the next generation of providers comes up. So providing brown bag lunchers, curriculum additions, and lectures within the schools of nursing, public health, and medicine, not just at Johns Hopkins, but the University of Maryland and other schools in the area. So we're really hoping that the next generation does kind of know what to do with cancer survivors, that even doctors that are not going into oncology or primary care will experience cancer patients in their clinical practice, and it's important that they know what they should be doing and not doing to take care of them. We've published a lot of this data and done reports, and we're developing several national guidelines on survivorship, on preventative care through the American Society of Clinical Oncology. So getting that information out there. So there are real guidelines that primary care can follow in terms of taking care of these patients. And as I mentioned, the transition visits, which we've already implemented, and different mHealth options, mobile health options that are accessible to all patients. So in conclusion, we know that providing good follow-up care is accessible and is available, even in a big clinical practice such as a place like Johns Hopkins. But it's important to incorporate everybody, patients and all providers, and getting buy-in from lots of medical and non-medical providers at the place of where people are being treated. We think that our transition visits are hopefully helping patients transition after their cancer is done. And our data suggests that having a multimodality approach, so providing electronic resources, print materials, and ideally having this transition visit is most ideal for these patients. And then the idea of providing this information for people that don't have the availability to have these one-on-one visits is really important. And that's it for me. And if you have any questions, feel free to email me or you can find me on Twitter.